Watu wa Siaya muko? Wapi vigelegele ya Siaya? Na Kisumu je? Na Homa Bay? Twende. Moja unazunguka, zunguka. Zunguka tena, twende. Jolua humor. Taya, hapa kwa Yesu. Hapa kwa Yesu. Taya, Abitunya taya. Abitunya dale. Abitunya taya. Sasa weka sideways namna hiyo. Wana miela. Agre. Wana miela. Ladies, we are not going away. Kujeni hapa juu kwanza. All beautiful ladies, if you know when ni daktari and you are beautiful, kuja hapa juu. Luos, don't worry. We are still here with you up to Friday.
Okay, just hold on. Thank you very much. Our chief guest, Honorable Waziri, Susan Nahumicha, karibu sana for this session. I'm told that we want to welcome you with a song, Waziri, before we start. So please enjoy. Kayamba.
Waziri, with all due respect, hii ni yako. Manake, we are happy the way you are transforming the ministry. And in Luya, they normally say something beautiful is something that normally transforms the community. And we thank you the way you have transformed the ministry of health.
Yes.
And hii ni yako. Twende sasa. Kila mtu tusimame.
Shomode ina mukanga. Shomode ina mukanga. Mwanani ya lugha kedaga wishomo sunguza marina. Shomode ina mukanga. Shomode ina mukanga. Mwanani ya lugha kedaga wishomo sunguza marina. Namawa kawatora hunya. Namawa kawatora hunya. Namawa kawatora hunya. Namawa kawatora hunya.
Wapi vigelegele ya waziri?
Namaru kawatora hunya. Namaru kawatora hunya. Namaru kawatora hunya. Namaru kawatora.
Tingisha mabega twende. Asante.
Asante sana. Thank you very much. Our chief guest, Honorable Susan Nakumicha, our invited guests, and all protocols observed, good afternoon. Our chief guest, karibu sana to this HIV Delivery Integration Summit that is taking place between today and Friday. And the theme is reimagining the HIV response in the health sector. We are in this room with our partners from the development world, including UNAIDS. We have the regional director and the country director for UNAIDS. We have representatives from WHO, PEPFAR, CDC, USAID, Department of Defense, and from the private sector, we have representatives from Equity Group, Cooperative Bank, Roche, Patek, Chai, Global Fund, Gates Foundation, and many implementing partners in the space of HIV. And we also have distinguished delegates from the county, led by the County Executive Committee members for health, the County Health Directors for health, and the County AIDS and STI control coordinators. Among the Ministry of Health officials, the civil society, people living with HIV networks, including the young people, together with our online followers and audience. Chief guest, please allow me to invite Dr. Bashir to quickly just take us through the objectives of this summit and what we have done since morning, and then invite you to speak to us. Thank you.
Thank you, Dr. Sirengo. Our chief guest, Honorable Susan Nakumicha. All protocols observed. We are here today to celebrate our achievements and looking at the future for HIV/AIDS service delivery in Kenya. Waziri, we've been here since morning, and in a very short time, our teams from the Ministry of Health, NASCOP specifically, and our partners have really put up together a very successful conference, one of its kind, the only one globally. As you can see from the audience, very successful, and I want to congratulate the teams that have really worked tirelessly the last 3 weeks, because the concept itself was less than a month. It is HIV Service Delivery Integration Summit. This discourse is going on globally, but there's not a country that has taken up these steps. So we congratulate ourselves and your leadership and our teams and our partners that we have taken up this task, and we are being looked up to by other countries as a learning curve from this experience. The main purpose of this conference is the changing world of service delivery, including what's happening nationally, our health reforms, the UHC agenda, the PHC agenda, and of course the shrinking donor support and transitioning into domestic financing for sustainability. As a country, we've been discussing this. We are quite aware. This conference will help us really align our HIV response to the UHC agenda, share best practices from within the country. All the counties have ideas and specific agendas that they want to showcase, and so that we can learn from each other within the country and export it globally. And of course, recognize those who have been walking this journey with us as a country, from our scientists, program managers, our community members, give them award and recognize them. And thirdly, disseminate these policies as tools for attaining our universal goals, UHC, SDGs, and looking at integration models of HIV. If HIV fits well within our UHC agenda, then the rest of the programs will equally follow. So without much ado, we are happy today to have you on board. We knew that you are committed and you have been following us and supporting us. And the virtual participation shows your commitment. I know that you are not able to come here, and we've tried several times today, but this itself means a lot to us as your team members, and we are happy to welcome you. Please welcome and address the audience. Just to inform you that we've a bit changed the protocol. Our partners have not spoken before you. Because of your busy schedule, we'll give you the time to address us, and then we will continue with the program as was planned. Karibu Waziri. Please welcome Waziri with Karibu Sana, Madam. Sorry, Waziri, you can restart. You can restart. We were not hearing you. Sorry.
Okay. Thank you very much. You can hear me now?
Yes, yes, madam.
Thank you. Esteemed partners, ladies and gentlemen, good afternoon. It's my pleasure to address you and to officially open this very important summit. Let me appreciate my teams at NASCOP, the Ministry of Health, and the partners who have worked together with them to put this summit together. Asanteni sana. Kenya's response to HIV has been long and has taken many faces. I wonder how many in the room there were born in 1984 when the first case of HIV was detected in the country. Since the first positive case, there has been no greater public health concern for Kenya than the HIV pandemic. Indeed, it was upon the realization of the profound impact of HIV on the socio-economic fabric of our nation that the government declared HIV and AIDS a national disaster in 1999. At the time of the declaration, our situation was dire. A high number of very sick people were turning up at our health facilities with mounting deaths. In fact, the situation was so bad that at some point, the national HIV prevalence was in double digits. The government has continued to demonstrate strong political commitment for the HIV response. Since 2000, the country has implemented various strategic frameworks, enacted many supportive legislations, and established coordinating bodies to support the response. Throughout the response, the government has prioritized strengthening the healthcare system to address the HIV pandemic and other public health challenges. Distinguished participants, I am pleased to note that as a country, we have come a long way and have made remarkable progress. Through concerted efforts by the government and all partners, we have managed to lower the rate of infection and overall prevalence rates while enhancing care for those infected. Today, Kenya has an estimated population of 1.4 million persons living with HIV, translating to a national prevalence of 3.7%. At the end of December 2023, 1,336,234 people living with HIV were receiving treatment. To make services more accessible, we have increased HIV service points and taken the services closer to the people. Currently, there are 8,851 HIV testing sites and 3,752 treatment facilities across the country. Within the last 10 years, there has been a remarkable decline in new HIV infections, HIV-related mortality, and mother-to-child transmissions by 78%, 68%, and 65% respectively. It is a strong partnership and collaborations with every stakeholder here that has transformed the response and made these remarkable achievements. The partnership has laid a solid ground where today we can jointly advance global efforts to end HIV/AIDS as a public health threat and strengthen public health systems. These achievements are not just the work of government. I must at this juncture, on behalf of the Ministry of Health, Kenya government, acknowledge and appreciate wholeheartedly the contribution of various partners for supporting the HIV response. Asanteni sana. Esteemed partners, despite these achievements, there are still gaps in client outcomes among specific subpopulations. Geographical inequalities, while stigma, continue to impede optimal HIV outcomes. Moreover, the quality of life for people living with HIV on long-term treatment is an emerging concern, particularly due to the increased risk of non-communicable diseases and mental health needs. Addressing this requires a holistic, patient-centered, and integrated approach. Kenya's HIV health service delivery currently operates predominantly through vertical programming, which results in high costs, parallel services, and gaps in quality of care. Specifically, for clients whose needs span beyond HIV, such as those with non-communicable diseases, e.g. hypertension and diabetes, the virus-only tragedy-specific care leads to suboptimal outcomes and unresponsive client experience within the health system. The isolation and specialized labeling of standalone HIV comprehensive care clinics further contributes to stigma and discrimination within health facilities. The Ministry of Health is committed to redesigning the HIV response to align with and contribute to the health reform agenda aimed at providing access to integrated, people-centered healthcare services to securing progress towards ending HIV as a public health threat. We can rapidly address the gaps and accelerate progress through integration and institutionalization of public health response mechanism that aligns with strong political commitments for health sector reforms under the government's universal health coverage agenda. This summit is taking place at an opportune time, and it is my expectation that its proposals will look at how to best align the HIV response to the reforms currently going on in the healthcare sector. Specifically, I call upon a renewal of mind and collaboration by all stakeholders in the following areas. 1, strengthening of government institutions responsible for HIV prevention, diagnosis, treatment, safe blood supply management, supply chain management to the last mile. This includes review of financial support models from stakeholders, including PEPFAR, to increase proportional funding through government-to-government funding mechanisms at all levels. 2, building on His Excellency the President William Ruto's health reforms to operationalize universal health coverage through primary health care strategy, as the anchor for transformation of HIV program at all levels, especially at the county level. Kenya will redesign HIV service delivery models to increase efficiency, promote equity, and maximize resource utilization while achieving the goal of ending HIV as a public health threat. In this regard, let the stigmatized standalone labeling of HIV services and clients in facilities cease by a reorganization of service delivery points through integration to other service delivery area or transformation into broader chronic care models. 3, aligning the funding available in HIV response in support of operationalizing the Social Health Authority that includes HIV prevention and control in the essential benefits package with the context of publicly financed primary health care. In this regard, it is important to note that HIV care is included in the package, even as the transition of financing model is discussed. The great news is clients being at the center for NCDs and advanced HIV disease is captured under this new model. I urge all our people living with HIV to enroll and be members of the Social Health Authority. 4, we need to strengthen and utilize Kenya's enormous potential for local manufacturing pharmaceutical and healthcare products to significantly contribute to HIV commodity security while also propelling Kenya towards sustainable growth. Kenya boasts the largest pharmaceutical industry in both the East African community and the COMESA region, and capable of producing over 90% of drugs on the essential medicine list. 5, innovation and digitization as prioritized by the government through enactment of the Digital Health Act of 2023 within the Ministry of Health's primary healthcare strategy is core. Let us all fast track and commit this frontier as it holds potential for increased access to services, efficiency, and cost saving. Lastly, we need to sustain research and evidence-based driven public health response. For example, the new World Health Organization guidance on HIV testing is a testament of the need to remain committed to science and emerging evidence. As a ministry, in order to maintain quality of HIV testing, we have aligned to the WHO guidance and transitioning from 2-test to 3-test strategy. I'm glad to note the overwhelming support that we have received from our partners and stakeholders to support this transition, including the World Health Organization, Global Fund, PEPFAR Media, communities, counties, amongst others. Ladies and gentlemen, as I conclude, the urgency of rethinking the HIV response underscores the need for locally tailored solutions. I am aware that it is easier to say what needs to be done than to show how it should be done. I am thrilled that this meeting is seeking to compile actual practical examples to accelerate integration HIV redesigning agenda. We are here to listen and emerge from this summit with your great contribution to key shifts to inform policy and investments for a healthier population. This aligns with the Kenya Kwanza government bottom-up approach as the frontier in driving community and people-owned sustainable solutions. With a compendium of local experience of implementation, country-led and grassroots-owned interventions, I am certain Kenya will lead the way on how to rethink and redesign HIV response. I want to therefore acknowledge with admiration the efforts and immense contribution and emerging evidence from the county governments, the partners, and communities that will accelerate our noble intention of rethinking the HIV response and sustainability through integration. It is now my singular honor to declare the HIV Service Delivery Integration Summit officially open. Asanteni sana. I would have loved to be there with you, but due to exigency of duty, I have managed to be with you online. Thank you very much to all the participants. Thank you very much to Kayamba Africa for the nice welcome song. Asanteni sana. Thank you.
Thank you. Thank you very much, Honorable CS. We are elated and we are encouraged that you have managed to be with us, albeit virtually. We don't take it for granted, and we really appreciative of your efforts. Now, we will now go back to protocol and allow you maybe time to go off, and then we can continue. Thank you very much, Honorable Minister.
That is done.
Thank you very much. So I will now call upon the chair of the session, Dr. Sirengo. Thank you very much for the smooth transition. For us to continue with our remarks and presentations. Karibu, Daktari.
Thank you, Dr. Bashir. Now, before we went for lunch, there were questions. But we would like to have those questions as one plenary at the end. With your indulgence, therefore, allow me to invite several speakers, and in the interest of time, kindly limit your word count. Asante sana. So without much ado, now we are back to the program. We'd like to invite Patricia. Patricia has been walking this journey of HIV response for a long time to share with us some of her thoughts about this journey and what she thinks about integration. Patricia Acero, welcome.
Good afternoon. Good afternoon once again. To the distinguished guests, ladies and gentlemen, fellow colleagues, community members, all protocol observed. I want to thank NASCOP for inviting me to speak at these HIV deliveries. As a person living with HIV, who is also aging with HIV, I'm honored to share my perspectives on how we can re-emerge a substantial HIV response in the health sector. I heard Dr. talk in the morning about how it was in the beginning. And for those ones who are working at Mbagathi Hospital, where I was in the year 2000. I remember sitting in a room with clinicians, and we had 200 kits to start treatment, yet we had 4,000 patients. As a counselor, as a community member who was working with the patients, that time there were patients, they were not clients, they were real patients. The files were blinded so that we could not favor anybody. And then the criteria was 200 CD4 and below. You have to be living in Nairobi. You need to have a treatment buddy. You need to have had a certain number of counseling sessions. But the problem I had at that time is that as much as the files were blinded, I knew each and every client by heart because they passed through me. And as a file was thrown away, that one was not going put in treatment, I felt like dying. But then I also knew that we only had 200 slots. So when the 200 had been chosen, they were sitting, my peers were sitting outside the door and asking, Pati, why was I left? Were you not able to tell them how bad things are for me? It was 200 slots. But I'm happy to stand here today, and I heard Rose and colleagues saying that we have 1.3 million. 1.3 million people on treatment from 200. So tujipigie makofi. For the national government and the counties, we have a legal and a moral obligation to ensure that HIV and TB services are, one, available. So as a treatment advocate, when I'm talking about availability, I mean availability. It's not the time when I have to go sit on TV and say, we don't have this medicine, erratic supply. I'm talking about availability. That if I walk into that facility and I have TB, then let me be given my medication for TB. I'm saying the county government because I know the health is devolved. That if a patient walks in, you have TB, you've been sick for a while. Sometimes you are down, even your hair is falling off. And you've come in and you've just been told you have TB. Then you are being told, hakuna dawa, pengine ukuje next week. How does that make you feel? Yet you can't walk into Aga Khan or Mata to get your medication. So when we're talking integration, I'm asking for availability. Ama nimeuliza sana? Mko sawa? As a treatment advocate, I have to say that. And the issues around affordability. We've just been told right now about the number of the pharmaceutical industry that we have in the country. In 2001, we were on the streets asking the government to have a patient-friendly intellectual property bill, to have TRIPS flexibilities enacted into our constitution so that they could be used. The Ebola exception, the governmental use. All these things are in place, but we don't use them. So when we're talking about affordability, let us use the laws that we have to make sure that our people can have access, so that they're not just some papers sitting somewhere, but there are things that we can be able to use to make sure that we have what it takes. Integration of services. My concern as a person living with HIV is the doctor strike. Ama nasema uongo? See, just the other day the doctors were on strike. If we did not have a parallel facilities, then people living with HIV, we have to take medication every single day of the month. Then the doctors are on strike for 6 months, for 3 months. Where will we get our medicine? So when we're thinking integration, what is this that we need to do to make sure that our doctors don't strike? Is it the salaries? Is it the working condition? What is it that we need to do? Erratic supply of commodities. Ama mnasikianga vizuri nikienda kupiga kelele Citizen. So just the other day I was there asking for vaccines. So when we are talking about integration, I'm even talking about those vaccines. Why should our children miss vaccines? Why is it that at times we don't have reagents to test children? And that is how we miss the children. That is how children end up having advanced HIV disease. And that is how they die because we did not get them on time and we are not able to put them in medication on time. For me, when we are talking about integration, I'm asking for commodities to be in place so that we have everything the way it's needed. If it's the child, they are tested. If it's the woman, she's tested and put on treatment. Imagine going to the facility as a pregnant mother and you cannot be tested for HIV. Just an HIV test. And that is the basis where we can be able to start treatment. It is good to talk about the 3 algorithms. But where are those commodities? So for me, when we are talking about integration, I want to see the commodities. I want us as a country to invest in research for new treatment, vaccines and cure, and strategies, which will continually improve existing interventions. So because if we don't invest in research, we saw during COVID, ile ikukua ati nini, ama tu kuona, we were at the tail end of the queue because we did not invest in research. If we had invested in research, when people started vaccinating their countrymen, then we would also have been started to be vaccinated. But we lost people. Why? Because we did not invest in research. So as a country, when you are talking, for me, when you are talking integration, you are talking research. The digital superhighway that we are talking about, for me, it is not just about the names, the records. It's everything. When we're talking about the digital superhighway, it's everything from human rights, making sure that I can be able maybe to access my treatment online. Right now, this is how my leg looks. So when we are saying we are aging with HIV, sometimes people think it's just things that people are talking about. The NCDs are real. I live with a heart condition. I live with blood pressure. My sugars have just gone out of control. I have asthma. And then everything else is coming in. So when we're talking about integration, who is this person that you want to see me in the health facility? Is this the CHP? That I'm talking about the human resource. Who do you want to see me in the facility? HIV services are decentralized, but who ends up seeing us in the facility? The raw truth, I walk into one of the facility, I'm from Kakamega. I go to Chevoso Health Center, and the person I'll get there is a peer educator. Can they handle my case? I'm taking antiretroviral medication, I'm taking hypertensive, and this is my fit. And who do I walk into? A peer educator. So when we are talking about integration, those are areas that I want to be looked into so that there's quality. It's not just a facility, and then we are saying we have given CHPs packs to take care of people. They cannot take care of me. I have a chronic condition that needs quality care. So we talk integration, we are looking for quality. We have HIV, and that does not mean that we should be handled like baggage. We should be given quality care when we go to facilities, whether it's at the primary level or it's at level 4, because some clinics are called level 4 and you don't even have a lab. So what we are asking for is quality services. The last but not least, as we continue to do integration and even as we think of sustainability, as communities we are asking, Joyce said here before, I'm saying it again, that for us advocacy has to go on. We have to be able to hold the government accountable, and for that we need funding. So you cannot just say that communities at the center, how will we lead if we do not have funding, we do not have resources, and our capacities are not built. So thank you so much for the opportunity.
Thank you, Patricia, for that very nice testimonial. We have not done justice to Patricia. Thank you. As you saw the statistics that were shared here in the morning, that The HIV epidemic is diverse, and the young people are disproportionately affected. Just like we've heard from Patricia, I would like to invite a young person. Jerop, are you in the room? Jerop Limo, to come and share with us her thoughts. In the absence of, is there somebody representing Jerop? Joshua. Okay, we also have a spoken, okay, Joshua is here. Joshua, please come and share with us your thoughts about this integration. Does it work for you or it doesn't?
Thank you very much. All protocols observed. Good afternoon. I'm humbled to represent the young people in this country for this official opening of this forum. And I want to really appreciate the effort that you have put in place so that we also be able to address this nation. So in the morning we had some presentation that showcased adolescents and young people being one of the populations that we really need to look towards too. And we have to appreciate that the country has progressively moved forward in terms of engaging young people, but we still need to drive more towards putting more efforts in terms of co-designing and reimagining where we want our adolescents to be in the next future. I know we have targets for this country, but it's very essential that we look out ethical engagement of adolescents and young people. So it's very important. I know as we talk about integration, we also need to ask ourselves, what is integration for us as young people? And a couple of weeks ago, some of the young people went to look through the youth wellness centers in the country. There are only 5. And we realized some of them are a one-stop shop for us, which is a plus to us. But we still want to stress on commodities availability. We also realized that with a lot of reforms, the primary health care, the universal health coverage, we ask ourselves, where are we at that table? Someone once said, if you're not on the table, you will be on the menu. So we still want to ask ourselves, we want to be engaged meaningfully and ethically. Remember, this population bears over 70% of this country. I know we have a paradigm shift towards HIV prevention, and it is very important that we need to look at, just as other community members have outlined, people-centered approach. And we also join hands together that we also want adolescent-centered approach. And let us also include the availability of the new HIV methods that are also oncoming. Thank you very much, guys. I am humbled to have presented the young people at this forum. Thank you.
Okay, thank you, Joshua. Joshua has said that he would like to see many of the youth-friendly centers operationalized across the country, which is a one-stop shop. with commodities, not just a shell of a service delivery point. Thank you very much. We are happy when we listen to the young people speak to us, because sometimes we program for adults and think that what works for them also works for you. It's now my pleasure to invite private sector players to speak to us. And as I'm seated down there, I'm asking myself, how does integration in the space of diagnostic solutions play about? So without much ado, please allow me to invite Ida, Dr. Ida Mbute, to come and tell us how Roche is doing this. We know Roche is a big player in the space of diagnostics. Karibu.
Distinguished guests, ladies and gentlemen, good afternoon. I'm delighted and privileged to be standing before all of us today to highlight the crucial role that the private sector plays when it comes to health and reimagining a sustainable HIV response in Kenya within the context of universal health coverage. I start by highlighting that this summit represents a crucial gathering of hearts and minds dedicated to tackling one of the most significant health challenges of our time, which is HIV and AIDS. As we gather here today, it's imperative to acknowledge that Kenya has made tremendous progress in this fight thanks to the tireless efforts of NASCOP, the Ministry of Health, and multiple other stakeholders. We have witnessed significant advancements in prevention, treatment, and care. However, the journey is far from over. The integration of HIV care into the universal healthcare coverage model is essential to sustaining and also accelerating these gains. The private sector plays an important role in sustaining efforts on universal healthcare by bringing together a unique set of capabilities, resources, and expertise that can complement the efforts of governments and implementing partners in tackling HIV and AIDS. Private healthcare providers, laboratories, pharmaceutical and diagnostic companies, as well as technology firms, have the potential to contribute significantly to this disease by leveraging their strengths. Universal health coverage aims to ensure that all individuals and communities who are important, as highlighted here before by Patricia, receive the health services that they need without suffering financial hardship. Integrating HIV care into universal health coverage is not just a health imperative, but a moral one. It ensures that no one is left behind, regardless of their HIV status. In a groundbreaking move toward advancing universal health coverage and health equity, the World Health Organization passed a resolution on strengthening diagnostics capacity. The resolution, which was adopted at the World Health Assembly in May last year, addresses the challenges of access, affordability, and quality of diagnostic tests. As a representative of Roche Africa, I would like to highlight the pivotal role diagnostics play in integrated HIV care. Early diagnosis, continuous monitoring with effective management of HIV are the cornerstones of our approach. Diagnostics are not merely tools, they are lifelines that provide critical information, guide treatment, and monitor progress. Diagnostics play an important role in early detection and diagnosis of disease. Timely and accurate diagnosis is the first step in HIV care. Advanced diagnostic tools enable early detection, which is crucial for initiating antiretroviral therapy at the right time. Early initiation of antiretroviral therapy not only improves individual health outcomes, but also reduces the transmission of this virus. Diagnostics are also key in monitoring and management, whereby continuous monitoring through viral load testing and other diagnostic tests ensures that antiretroviral therapy that's being administered is effective. It helps in detecting treatment failures early and making the necessary adjustments to therapy. Our diagnostic tools are designed to be accessible and reliable beyond just focusing on the virus, but also to include diagnostic tests for comprehensive and patient-centered needs for those living with HIV and AIDS. In other words, looking at them comprehensively as a whole. In integration with other health services, diagnostics also play a crucial role in integrating healthcare with other services. As an example, routine screening for co-infections such as TB and hepatitis, which are prevalent among people living with HIV, can be streamlined through integrated diagnostic platforms. While the benefits of integrating HIV into the universal health coverage model are clear, there are several challenges that must be addressed. Firstly, infrastructure and resources. Strengthening health infrastructure and ensuring the availability of resources, including diagnostic tools, as well as trained personnel, is fundamental. Public-private partnerships can play a significant role in bridging these gaps. Secondly, and this is a big one, stigma and discrimination. This remains a critical component. We must continue to educate communities and advocate for policies that protect the rights of people living with HIV. Additionally, I'd like to highlight sustainability of funding. Sustainable financing models are essential to support the integration of HIV care into universal health coverage. Innovative funding mechanisms and efficient use of resources will be key to our long-term success. The private sector's involvement in these and other areas, I must admit, is multifaceted, and it can significantly enhance the capacity, the reach, the effectiveness of NASCOP's integrated HIV service delivery efforts. Collaboration between governments, implementing partners, the private sector is essential to not only mobilize resources, but also share best practice and drive sustainable change. Through service provision, innovation, capacity building, supply chain management, public-private partnerships, advocacy, research, and funding support, the private sector can play a pivotal role in addressing the HIV epidemic in Kenya. The integration of HIV care into the universal healthcare model in Kenya is not an option. It is a necessity. It is a collective responsibility for all of us, and it requires our concerted efforts as stakeholders to include not only government agencies, but healthcare providers, the private sector, and most importantly, the community. At Roche, we are committed to supporting this vision through innovative diagnostic solutions, capacity building, and strategic partnerships as well. Our goal is to ensure that every person living with HIV has access to the care they need, which is integrated seamlessly into the broader health system. We are also dedicated to collaborating with the government, global policy makers, communities, and other stakeholders to enhance access to diagnostic solutions that address unmet medical needs and thus enabling early detection, prevention, diagnosis, and prognosis for improved health outcomes and a better quality of life. As I conclude, I would like to reiterate that as we embark on this journey towards integrated HIV and AIDS care within the universal healthcare framework, let us be guided by the principles of equity, inclusivity, and sustainability. Together we can build a future where every Kenyan, regardless of their HIV status, lives a healthy and fulfilled life. Thank you so much for your attention, and I look forward to our collaborative efforts in making this vision a reality.
Very good. Thank you, Ida. I was hoping that you'll answer one of the two questions I had about public-private partnerships in diagnosis. Should I ask them now? Let me ask so that you prepare answers as we come to the plenary at the end. Number one, I know manufacturers are very good at what they do, and you develop what we call closed systems. of diagnostic machines. What is your opinion about open systems as a way of integrating a reagent from Dr. Sirengo to work on your platform? Since it's a heavy question, I'll just keep it to that. You may want to say something about that. Eh? So thank you very much. Let's clap for her. The next speaker is my friend. He was a very serious CEC in Muranga before he crossed into private sector, Joseph Mbai, who now works with Equity Bank. And I'm wondering, what has Equity Group to do with integration? I'm waiting to hear from you. Karibu. Thank you. Let's welcome him.
Thank you, Doc. Thank you very much, Dr. Sirengo. All protocols observed. Good afternoon. I came with a colleague of mine. I think it's important. Dr. Peter Gikonyo works with me at Equity Bank, and we are representing the group today in this summit. Gikonyo, they haven't seen you. You need to come here. My name is Joseph Mbai. I'm the General Manager in charge of health sector at Equity Bank Kenya Limited. And how many people here are members? If you are a member, can I see by a show of hand? Wow, 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 wow. Thank you very much for supporting us. Dr. Gekonyo works with me. As you are aware, Equity Bank Kenya Limited has actually made a deliberate move to support the health systems in this country. And we have actually gotten quite a number of colleagues in the system. We have Dr. Dennis Ogola, who was working with Avenue Group. He's the Group Director of Health Sector at Equity Bank. We have Dr. Samora, who was working with FDC, who is now heading operations at Equity Group Foundation. We have Dr. Joanne Coril, we have Dr. Joyce Tonik, and you can see as a bank, we've decided to raid the health sector in a big way, so that we really want as a bank to have a conversation. How do we support the health systems in terms of financing? Because there's a serious gap. When I worked in Muranga County as the CEC, it is not lost on me that finances were a serious problem, even for simple interventions. So as a bank, we want to live to our purpose. You can sit, thank you. We want to live to our purpose, and our purpose is transforming lives, giving dignity, and expanding opportunities for wealth creation. So Dr. Sirengo, when you say that you want to know what Equity Bank can do, I want to tell you that Equity Bank has transformed lives. If you look at the model of Equity Bank, right from when it was a building society to when it's now a Tier 1 bank, we have transformed more than 21 million lives in this country. We have brought in financial inclusion. We brought money from under the mattress to the banks now. And if you look at the interventions we've done in women and youth, more than 2 million women and youth trained in financial education, more than 100,000 households impacted through clean energy and lighting, 2.6 million households reached on social protection programs, more than 120 Equity Afya clinics that have treated more than 2 million patients. And we operate a two-engine model. We have the social engine and we have the commercial engine, the one we call the economic model. What you see in Equity Foundation that supports Wings to Fly. How many people here are familiar with Wings to Fly? Good. Wings to Fly is managed by Equity Group Foundation. We get vulnerable children who have passed well and are not able to pay their fees. We take them through the secondary education. We take them through university. And once they graduate, we have a financing model for them. In fact, the Equity Afya clinics you see are all managed by doctors who have qualified from the ELP program through Wings to Fly to Elimu Leadership, and they become doctors. And we have trained more than 1,118 doctors through that program. In the clinics, we are also employing a lot of medical staff, nurses, lab technicians, and you can see we are really working on something. Then what do we need to do for this integration, Dr. Sirengo? Number one, we cannot complain ourselves out of poverty. As a country, it is time now we must agree and say that people must work together to deal with HIV, TB, malaria, NCDs, and the diseases that really be there for our country as a growing nation. Sometimes I go to meetings and I see very, very good presentations, PowerPoint presentations, very good research papers. But unless there's an umbilical cord that connects what we are doing here in this hotel and what Wanjiku is going through in Mathare, in Kariobangi, in Kisumu, in Mandera, then we shall never be able to solve this problem. I remember when I was in Muranga, at the time our indicators for mother-to-child transmission of HIV were very high. And then we were asking ourselves, how do we solve, how do we reduce from an indicator of 20% to even 5%, which is required? And as much as we cannot deal with the issue of teenage pregnancies, colleagues, let me tell you, we will never be able to deal with that thing called mother-to-child transmission of HIV. Because when they become pregnant when they are young, they will not be able to say in time. So interventions cannot be done. So as Equity Bank, there are 4 areas we can work together. And I want Sirengo to listen. Number 1, we can marshal the private sector. We can spearhead as a bank because we are financial institutions, and I know people, we are looking for money to support, isn't it? We can marshal the private sector to improve Kenya's HIV financing that is sustainable. You know, donors now, funds are dwindling. So now it has to suddenly become our business. We can no longer sit pretty and assume that support will come. We have to make a deliberate decision as a nation, as Ministry of Health, as a people, to support that. So we can bring all the stakeholders in all the sectors and create an account where we can fundraise and have those monies. We have 211 branches in Kenya. So when we speak as a bank and say we can be able to fund, to support and facilitate, when you are in Kisumu, you don't need to come to where Mbai is in Britam Tower headquarters. You can walk to Angawa branch or the one which is at the Oginga Street, and you can see we have teams on the ground that can do that. Then sectors of focus, health, MOH, Council of Governors, because health is a devolved function, and then communities, national government, religious. So marshalling we can do for you. The second thing we can do as a bank is economic transformation. We have done that before. We have experience. We have to zero in on young people, because when Dr. Lily was doing a presentation, I remember there's a slide where she said that 41% of the incidences of new infections are coming from the young people. Colleagues, if we want to win this conversation, young people must be at the center of the stage. We cannot deliver it unless we use the young people. And as a bank, if you tell a young person they are going to die, it doesn't register in their brain. So what do we want to do as a bank through economic transformation? We can evaluate for you, we can empower, and we can finance some specific initiatives that can make them money. If you find the key populations that are coming from Mathare Korogosho, sometimes when they go to do that business is because they have nothing to eat. So how do you help them get something to eat? So that when you tell them about HIV prevention, they can listen. So we can put in seed money, working together with partners, and because as a financial institution, we know how to manage better than, do you want to say better than you? As a financial institution, we lend money, and if a partner puts in seed money with us, number one, that money will earn interest. Number two, we can lend that money to those people you want to support and make it sustainable and scale it. Then, the young people also, sometimes it's difficult to know whether this person will succeed or not. As a bank, we have tools to assess capacity. We can even assess readiness to accept intervention. We can assess a young person for you and tell you, this one is ready to accept this kind of intervention, this one is not ready. We build capacity, we can give them opportunities that are available also in the bank. For your information, we have more than 70,000 agents across the country. And those agents are managed by business people. We can integrate those young people suffering from HIV to get some level of funding, and they're able to generate their own income through the agents, through the ECBs, through online businesses. Then the third thing, Dr. Sirengo, is develop co-funding model. The co-funding model, we just make a strong collaboration between the existing institutions that have the money, and we agree how do we do co-funding, and that can really help. And the final one, which we can do as a bank, is financial literacy and entrepreneurship. Because many people would go to school and probably they want to get into business. We can handhold them, train them, show them how business is done, financial literacy, entrepreneurship, and also teach them financial accountability. Because accountability is very key, even when we are doing interventions for HIV. And as Equity Bank, we can manage that for you. So if you ever had funds that you needed managed, put in a seed money, we encourage you to work with us as a bank, and we can be able to improve the situations as far as HIV is concerned. So with those many remarks, if there are any questions, we have a booth around. You can walk to our booth. You can speak to Dr. Gekonyo, is there. You can speak to me. And as a person, if you also wanted support, we also give personal loans, mortgage, car loans. Thank you very much, and God bless you.
Joseph, sorry, I think somebody switched the mic off for you. But well done. Thank you very much. He's an A student, isn't it? He answered the question I posed. Eh? Very well. Thank you. Let's clap for him. Thank you very much. I think we are doing very well, but not on time. I think we understand you've taken your many days to put in the best slides that you can have for this session, but let's also manage time. I would like now to invite Dr. Teresia, you're in the room? Yes, please. Teresa is the chair of the Public Health Society of Kenya, which is a professional society. She's coming to tell us how we can integrate ourselves as professionals.
Thank you. Good afternoon. My name is Dr. Teresa Kinyari Mwendwa, and I'm glad to have been invited here. I must say it's a privilege because I represent anyone who's done public health, masters in public health, and is working in the public health space. Is actually qualified to be a public health specialist in this country. So it's my privilege to be the chair of the Public Health Society of Kenya, and I'm glad to have this opportunity to share a few things with you. I think the most important thing is the kind of deja vu moment I had this morning when when the CS talked about 1984, who was here in 1984 when the first case of HIV was described. I was actually in Form 4. I don't know whether some of them were born, but did not have many public health specialists. We basically had a lot of public health officers. And that was the point at which I was lucky as a medical student to participate in a sexually transmitted infection study, which was part of a team that later became an STI control center, which was in the Department of Microbiology, and it became a WHO STI program. Now looking back, I can marvel at how far we have come. We have been able to build a critical mass of public health specialists, doctors, mainly doctors who've done public health, medical doctors, and also nurses. And I believe we are now at the right place where we can actually be able to say that we are ready to integrate HIV into the program, into programming. Let me tell you a bit about the Public Health Society of Kenya. This was formed by a group of public health specialists who work in the academia. I'm from the academia. We also have members from the public sector, which is the Ministry of Health. We also have members from the private sector and also from developing partners, faith-based organizations. Just think about anyone who works in the public health space in Kenya. Those are members or potential members if they haven't joined. And I don't know whether I can ask by a show of hand, anyone who's done public health, anyone who considered themselves a public health specialist. Maybe you can put up your hand based on that description. Thank you. Thank you very much. And that really shows the kind of diversity and the kind of localization we even have even in the counties, that you can actually be able to pull together this integration. We cannot pull together this integration without resources, and yet we've talked about having a dwindling envelope. But by virtue of our existence in our different locations, for example, I'm in academia, I teach about aging, the physiology of aging. And looking at someone like Patricia standing here at her age, I actually marvel at how we can be able to work together to just study the HIV aging. Our patients who are living with HIV are aging gracefully. This is one of the ways in which you can be able to. We have members who are lawyers in our society. We have members working in all diversities. So I feel for us to be able to integrate, to have a more integrated approach, we need to come together in our different areas of expertise and location to identify what are the key issues that we can be able to put together and be able to make it a more patient-centered service. And I can start, for example, with the aging HIV patient. You know, let me make it a bit easier when it comes to science. And this is more important for anyone here who may be living with HIV. If you're living with HIV, you have a disease for a long time. And because if you have a disease for a long time, your body has been seeing disease for a long time. So it gets more charged, it resets itself to a higher level, and it becomes more stronger in that sense. So I believe patients who have HIV are actually a good example of how somebody can age and age with a managed disease. We still do not know much about what healthy aging is, but I feel if you're able to integrate HIV services, we'll be able to improve the way older persons are treated and how they are managed in our setup. I think we focused a lot on adolescents and young people. We focused a lot on neonates and young children. But now we know that our population is half of our population is less than 20, which means that 40 years from now, we'll actually be having a larger population of older people, even if they are not HIV infected. So in terms of operations research, this is an opportunity for us to be able to look at how are people aging in the normal setup. How can we be able, for example, I was giving an example of blood pressure. If you take blood pressure as a person who is older, you need to take it the same way you take a woman who is pregnant. So we can have ways in which you can be able to integrate these services within the system. And when you think about it, there are very many changes in a person when they are older, and if a person living with HIV then can be integrated in all these services and get the appropriate services with all the other people without one being able to be identified by their status. The other thing also that I wanted to talk about is, I know Dr. Mbai talked about removing the money from under the mattress, but I'm hoping in the Public Health Society we'll be able to remove things from behind the curtains. There are a lot of things that, looking at the stigma index that Otoma has actually put out, we still have a 46% willingness to test, and yet we are looking at 98% testing rate. I just wondered about that discrepancy. So we are hoping as a Public Health Society we can actually be able to come out together and remove what is really behind the curtains. One example that I can give is incest. We don't talk about incest a lot. We are talking about eradicating HIV among our children. Yet, in our community, we sit, when it happens, the families discuss, and nobody talks about. Do we have data from, for example, from the HIV tribunal linking up with the STI data and HIV infection data? Are we monitoring that? I think we've talked about community-led monitoring, and this is one of the things that we can be able to do. Have we been able to follow up and see how to deal with these issues? Nobody wants to talk about them, but I feel this is the time we need to get these things from behind the curtains. We also talk about sodomy. I don't know how you're going to call it, or people having same-sex attractions in high schools, and it's a big issue. But again, do we have the numbers? Do we have a way of screening for STIs among students and pupils who go through such experiences? And this is where now, as parents and teacher associations and as part of the Public Health Society of Kenya, we need to remove these things from behind the curtain and really bring them out. Because I believe if we cannot be able to remove some of these things from behind the curtain, it's only a matter of time, and we shall have a reversal of gains than we had before. So we actually have a devolved presence within our society, and I'd really want us to work together to be able to map the public health specialists who are working with our society, so that we can be able to pull data together in terms of microepidemiology and to be able to identify these diseases. For example, we've always thought of cancer of the esophagus being more common in Kakamega, but now we are seeing it more in Garissa and in the other places. So there are many things that we can do together without having to wait for a national survey. You heard the Kenfia survey is we need about $6 million, but there's a lot we can do together in terms of the routine programming. So I'd like to thank you for that, and I wish you a nice meeting.
Thank you, Dr. for your insights in public health sector. Like I said, we are doing very well, but at this point, I would like us to have an interlude from a young man call Kerry to give us what is called the spoken word, which was supposed to come later, but I think it's been a marathon of speeches, and then we'll proceed. Kerry, please come. Let's clap for him.
Hello everyone. Hi everyone. Kila mtu afanye hivi. Alafu hii side ingine. Alafu zote. Haya, stretch sasa. So I tried to do something for the occasion, in line with the theme. All protocols observed. I hope you enjoy it. So? Once I was 7 years old. I didn't mind about my body features. I mean, I had no teeth, but I would smile at every single girl I would see on the street. I would occasionally walk to the barber with my mother, where the barber would ask, "Unataka style gani baba?" But before I could answer, my mom would say, "Toa yote." You see, the love that I had for my mom was so real. But it's kind of different when you're born with that HIV. But kama equipment ya DJ, President aliamua kuturn tables. Alisema 2027 mother to child transmission will be a thing of the past, and I know that we are able. Kwa sababu siku hizi tuko na ARTs, tuko na PMTCTs, na zinatumika vizuri kuliko poster time ya elections. You see, siku hizi kuna vitu zingine zenye hata mimi nimeacha. Tabia ya kujifanya pro, kuingiza madem box venye na drive Benz na hata siwezi afford pro box. Na wadanganya nitawashow sweet love yenye itafanya Mumia Sugar Company collapse. Na wadanganya ati nitawapeleka France, lakini ni chipo za 40 na wanunulianga nikiwachocha ni French fries. Hii ndio ile age yenye mimi mwenyewe nimeacha kudanganya wasichana. That Tuesday itakuwa terrific, lakini hakuna hata promotion ya pizza in. Ini ile age yenye even mimi nimeamua kuchange, kuacha kudanganya wasichana that I am not a player, lakini baada ya miezi 3 relationship yetu inaanza kuwa messy. Na wadanganya kwa nyumba yetu hata ipika na makaa, watakuwa napika na gas, lakini baada ya miezi 3 hakuna gas, ni stories za Fabregas. You see, mimi mwenyewe na wish to change. Na wish to change not just for me, but for my future generations. So you can change your life, mister, you can change your life, missus, not because you need it, but because of the future generations and our kids. Because they are the ones who need it. They are the ones who are going to bring in change. Ni kama conductor ame collect fare. Na unakumbuka hii HIV iko contaminated na germs za shetani, na germs za shetani hazijajiami, zimejiami. Hata ukikuja na sabuni ya panga haziwezi shtuka. So thank you NASCOP, thank you Ministry of Health, because siku hizi tuko na ARVs, tuko na PrEP na tuko na PEP. Kitambo hizo vitu zilikuwa unheard of kama democracy before independence. So niko hapa to tell you all my elders, my brothers and sisters, that this is the moment where we decide to bring in more change. This is the moment where we were united. So ukisikia in 2027 a kid is happy because ako HIV free na mama yake alikuwa infected, just know that it started now. Thank you so much.
Okay. We are going to do a 3 factorial clap. Let me see who are good in mathematics. So we prepare. 3, 2, then 1. Okay, we go. Thank you, Kerry, for that very nice piece that you've shared with us. This is the second and last phase of the speeches, and therefore, please join me in welcoming Anne Shangwe, who is the Regional Director for UNAIDS. I'm told she's just regional, but she's our daughter here. Karibu.
I'm John Boini. Good afternoon. How is everybody? I'm enjoying how our MC keeps saying we're doing very well. And then I look at my watch. But we're enjoying. No, we're enjoying. Thank you so much. And thank you for that brilliant spoken word. Thank you, Dr. Wafula and team, for the invitation. All our partners who are here with us, the communities, Patricia, Joyce, Grace, all who are in the house. Thank you so much. It's a privilege to be here, and indeed I am a child of the soil, and so it's a privilege to be here. Tomorrow, the United Nations General Assembly will be discussing HIV. And Kenya this year is chairing the board of UNAIDS' governing board. And as a result, we have to brief all of the member states about HIV. And on that agenda is HIV integration. So I came here for homework so that we can prepare. Also, next week is our governing board meeting, and we will have a whole day where we are looking at the issue of sustainability of the HIV response. And so this issue of HIV integration has become a big one in our conversation. And so it's important, and I said to Dr. Wafula that I really want to be here because it's an opportunity for us to explore. So, without repeating a lot of what has been said, let me appreciate so much the opportunity to be here and to congratulate the government of Kenya and partners and communities who have done an exceptional job. We're so proud when we work across the world because of the data and information we get about what's happening in Kenya. I noticed that last year when we were going through the numbers of who has reached the 95 targets, Kenya was not on our list of the top 5. But I noticed that the numbers are now saying that Kenya is actually at the 95 targets that we have expected. So we must congratulate ourselves, please. Very well done. It makes us proud as we're listing the countries who've achieved that we're including Kenya. When last year, as we were exploring what happens, we released a global report and we talk about what is it that has worked, that has made countries succeed. And I'll just go through a few key areas that I find the countries that have done really well have done, and that for Kenya, as you go into this HIV integration process, to really pay attention to. I think the one is very clear, and from the presentation you make, Dr. Lillian, really impressive presentation, is following the data, following the evidence, following the science is something that you're doing very well. But I think one needs to look even deeper into it. And I say this because, you know, the work and the issue of finding children and the points that were raised and the success that you've had with the rapid results process, I hear we're going to hear about it later, but being able to find the children so we don't have that kind of data disparity that we see is one of the big areas that we have been really advocating for. Follow the data and focus it on what and where the gaps are. If men are not adhering, how do we find the men? If key populations are being left behind, why, where are they, how do we find them? If it's the young people, how do we ensure that every young person, wherever they are, can be found? So following the data, I think, is a really, really important one. But as we find that data, let's also find what it is that we don't know. And I appreciated the comments about the concerns about teenage pregnancy somebody was raising, or underage pregnancy, and the fact that many instances, they're linked. The issue of underage pregnancy and children that are falling through the cracks, really, the fact that we need to connect these as little epidemics of their own so that we're able to connect them and solve the problem, I think is one important point. The second one is about inequalities, and it's linked. And just to say that we've been very proud of you, Kenya, as you've made the connections between gender-based violence, you talked about it in your presentation, HIV infections, sexual and reproductive health services, amongst young people in particular and adolescents, and adolescent girls in particular, because we can talk about adolescents and young people, but there is a difference, and your figures were showing us that at least girls are twice as vulnerable as the boys. So we have to be able to make that distinction in the inequalities work. And so when we look at this issue of inequalities, that work that Joyce presented on stigma is really, really important, because in other countries where we're doing this same work, we are seeing how the stigma and the culture of services are actually driving down our ability to integrate, to our ability to provide excellence in our services. But also this issue of inequalities is how you think about HIV and where you position your HIV work. We went to visit a clinic in Mozambique. In Mozambique, you've got, in the north, a terrorist context. You have floods and cyclones on a constant basis. And then you have your constant, 190,000 people living with HIV. And as they contend with this issue, we found in a clinic very sophisticated HIV services, Dr. Wafula, very sophisticated machinery that had been put there by our partners, right? But on the other hand, we saw a string. I was walking past with a group of my colleagues, and they were all walking past, marching very excitedly to the HIV section of the clinic. And as we walked past, I noticed a string of teenage pregnant girls in the ANC clinic. But because we were thinking about HIV and not about ANC, we were not paying attention to these teenage girls. And so we were walking right past them and not making the connections. And so the equipment that was being used for HIV was not in any way, used for those who were in ANC, because they had absolutely different services. Similarly, young people had a small little room in the corner where they would go and have almost like counseling sessions, yet their issues were bigger than that, right? Then we visited Rwanda not long after that. And what do we find? In one clinic where there is zero mother-to-child transmission, they have excellent one-stop center for all kinds of GBV-related services, for underage pregnancy, for the provision of care for young people, but at the same time, full HIV integrated services and NCDs in one small rural clinic. So the examples exist, and I think Kenya is saying that they're existing, but we have to keep paying attention to how do we recognize what are the barriers to our ability to integrate those services. I think when we look at your UHC and the fact that you've launched this, congratulations to Kenya also for driving this work, and the PHC, and we've heard about the health promoters systems, and we're very excited about that. I think the big thing is going to be how do we do efficiencies. How do we really think about these efficiencies and optimization of these services? I used to work on human resources for health a whole lot before across Africa, and it was the toughest case because if my budget, and I mean, I'm not PEPFAR, he'll come and speak, but if my budget is coming from a particular funding channel, and my budget, UNAIDS or WHO or whatever, is coming from the Swedish government, and somebody else's budget is coming from someplace else, how do we integrate this? Because we as partners have to think about that. We have to ask ourselves those questions. How do you integrate them? Namibia has done a very good process where they require that the funding, what you were talking about, the government to government, I think Minister was talking about, they've developed a mechanism where the funding goes directly through the structure of government in a way that all human resources for health is unified. So there are examples that are out there, but they're tough and complex, but we as partners have to do our own integration to be able to integrate with you. And so we are doing our thinking about that as we move along. And so you've been hearing us talking about a sustainability process. We've been in discussions with you about how do we build for sustainability. We've been working closely with PEPFAR and the Global Fund on this. And we're asking ourselves all these questions and working with you to think through this. How do we look and work closer with you about the localization of implementing partners so that our resources reach further and have longer term investment in Kenya and the capacity of Kenyans. These are difficult, they're controversial. In some instances, we don't win, but I think it's important that we're asking these difficult questions as we push for this integration. And then I want to talk about the issue of communities. And last year we had the big campaign, Let Communities Lead. This is not just a campaign to have. It is because we know that when communities lead, we actually see the difference in the delivery of services. In our global report strategy, we developed targets for the contribution of communities to the delivery of services. And in that, we actually have specific targets to say that, whether it's for GBV services, we need women and girls or communities, KPs, whoever are those violated, to be engaged themselves in leading the prevention services for GBV, for instance, or engaged like you are with the community-led responses, community-led monitoring, much, much more strongly. So the targets exist, the examples are there, but I think that being able to look at how to draw all these pieces is really, really important for us. And so we look forward to walking this journey with you. We are learning from you, Kenya. We think there is a lot to learn from your county, the different counties, and I really appreciated your presentation at the beginning, Rose, as you were showing how different counties have specialized in integrating different pieces. But we want to see which is that one county that will integrate all of them, and how do you create that efficiency through that, and does it work, and how do we all then support it so that people living with HIV and all those who need the services earn them. So congratulations and thank you for having us here.
Thank you, Anne, for giving us very good examples from the region and posing very tough questions. When we integrate, who is the winner? That's my key takeaway. When we integrate, who is the winner? Who should be the winner? Let me put the question. All of us. But more importantly, the client. I see you awake. Thank you very much. I have some good news that we have only 3 presentations left. Is it not good news? Yes, it is. We have a speaker online, please confirm if we have our speaker online. Who is the next presenter? Mr. Paul McCarrick, the Kenya Country Portfolio Manager for the Global Fund, who is going to speak to us. Paul, can you hear me? Technical team, do we have Paul on the line? Good afternoon, Paul. Can you hear me? Newton, please give us a go-ahead if we should proceed and wait for that connection. We can hear him? Okay, means we proceed with the presentations or we wait for him. Okay. As you connect, we can do one more presentation. Okay, here he is. Paul, can you hear me? If you are speaking, kindly unmute. Hello? Okay. Team at the back, should we proceed? 1 minute. Okay, as we do that, can we all stand up and stretch? Let's all stand up. Please get some space. You need space for this small exercise. Also get a partner. We do it in pairs. Anyone who feels like joining me can come up here. Please get a partner. People of key populations, don't start profiling us. Okay, so we are going to sing this song that says, Asante Sana. You know it, eh? Okay, let's go. Asante sana kwa kazi nzuri tuliyofanya. Asante. Where are your partners? Yes. No, that was a demo. That was a demo. So when you say asante, you high five with your partner, with your two hands, not one, eh? With your two hands. Okay, we go. Asante sana kwa kazi nzuri tuliyofanya. Asante. Okay, faster. Asante sana kwa kazi nzuri tuliyofanya. Asante. Thank you. Technical team, are we okay? Okay, I am being asked that kazi gani tumefanya. Tumefanya kazi nyingi sana. Sitting the whole day, listening. Okay? Thank you. So please allow me to, I hope, Brian, you're ready. Let me invite Brian, the director PEPFAR country coordinator to speak to us.
Okay, good afternoon, everyone. It's really my honor to be here. And I remember, Rose and I have had some conversations along the way about integration and sustainability. And it's really great to be able to see a lot of it come to fruition. And I was taking a look at some of the posters along the wall, and it's really great to see, some of the things that you've all been doing as we were kind of talking about it. So you've been actually doing it. So a huge thank you in that regard. I really think that this summit's going to be a great opportunity for us to discuss strategies that will help us to really reshape the HIV landscape in Kenya. And over the past 60 years, the United States and Kenya governments have worked together to build a more prosperous and secure future for Kenya. And this is a relationship that was demonstrated by President Ruto's recent state visit to Atlanta and Washington, D.C., which we were able to go there for. While he was there, we had a signature on a document that I think we have at the PEPFAR booth, if you want to come and take a look at it. And it's the guiding principles for the sustainability roadmap, which really gives us some of the highlights of how we want to move towards getting this sustainability roadmap in place by December 1st. And it's meant to be a starting place, not as an ending place. So for those of you who are like, I wasn't involved, the reality is we needed this as the one-on-one to get started. But the roadmap is one that's going to be really including all of you. And today is really the first step in getting us there. So by investing more than $8 billion US dollars in the last 21 years, to provide direct service delivery and the technical assistance needed to maximize the impact of the country's national HIV and TB response, PEPFAR is proud to be a long-standing partner of the Kenyan government and is supportive of its goal to end HIV as a public health threat by 2027. Emergency, it's the second word in PEPFAR's name. And when we first rolled PEPFAR out, we set up these separate services that were kind of parallel to the health service and the public health system, because we didn't think that the systems were strong enough. And that's in Kenya and really across Africa. But since then, we've really worked to build those systems, and we now believe that we're in a place that we can actually integrate the HIV in, and I think particularly in Kenya, those systems are really strong enough to be able to do so. As an example, as was mentioned earlier, we have now more than 1.3 million Kenyans living with HIV on life-saving treatment, and 94% of them have successfully suppressed the virus. While that puts us programmatically at the 95, or really close to it, I think we really need the KenFIA to come in, and we'll be doing that over the next year to really put the stamp of hitting 95 on that. And so we're really at the cusp, but we shouldn't rest. And my concern is that even if we're programmatically there, the KenFIA could come in and say that we're just under it, and then we have more work to do. But we have to continue working there. And those gaps, they really threaten the progress that Kenya has made in ending HIV, and we really need to work to close them. This can only be done through focused, sustained, and equitable action. The U.S. government is therefore proud of the steps and the political commitments that Kenya has made towards sustaining the gains, and will continue to support the country's long-term strategy, including the rollout of primary health care and universal health care. The current government's UHC strategy includes 4 laws that were put in place last year and really provides an important opportunity for the integration of HIV services. Increasing the domestic investments in health and integrating HIV testing and treatment services within Kenya's primary health care approach will go a long way towards sustaining Kenya's successes in the attainment of epidemic control. This integration can also improve the uptake of HIV services by making them more convenient and responsive to people's needs. Similarly, using electronic health information systems to advance client tracking to improve the accuracy of commodity planning and ultimately tracking and defining the progresses to achieve 95-95 targets are critical elements to the sustainable HIV response. In this regard, this week's deliberations will be helpful for us as we continue to reflect on the science behind what we do to improve and evolve the HIV response. President Ruto's commitment to universal health coverage through primary health care approach illustrates Kenya's determination to improve the quality of health care for its citizens. The PEPFAR team will therefore continue working with Kenya's leadership to develop HIV service delivery components that are aligned to Kenya's vision of universal health coverage. While development assistance for HIV remains crucial, Kenya can only protect the gains made in ending HIV by increasing its domestic investment in health. As such, this summit gives us a chance to explore opportunities for increasing the domestic responsibility in Kenya's HIV response and to ensure activities currently funded by donors, including PEPFAR and the Global Fund, are accounted for in the new Social Health Authority. Combining our efforts will go a long way in sustaining Kenya's successes in achieving epidemic control. And I also look forward to working with banks, including Equity, to see what they can do to bring to the table, because I think that's a great opportunity for us. So finally, although Kenya's progress in ending HIV is commendable, all groups have not benefited from this achievement the same. The inequities and inequalities that fueled the spread of HIV more than 20 years ago have not been fully eliminated. Necessary HIV prevention services for people from key and vulnerable populations, including adolescent girls and young women, children, people who use drugs, men who have sex with men, sex workers, are all still insufficiently available. The PEPFAR team will work with all stakeholders within the HIV space to adopt people-centered approaches that lift these inequalities and decrease their vulnerability to HIV. We cannot leave anyone behind. We look forward to ensuring all of our gains will be sustained for the next 20 years and beyond. Asante sana.
Thank you, Brian, for those wonderful remarks. PEPFAR has been here with us for the long haul, and we look forward to continuing the journey. Are we on now? Paul, can you confirm you can hear me?
Good afternoon. Can you hear me, MC?
Yes, please, go ahead.
Apologies for that, everybody. I'll be brief. So good afternoon, and thank you for your patience. And thank you, Dr. Wafula, for the invitation. Allow me just to start with apologies for not being able to participate in person, and also just to observe all protocols. So the Global Fund, we're supportive of the ambition, of the planning and the discussion that you are having. And it's, as we've heard, it's a very important discussion in the context of sustainability, which is a big word. And it's getting bigger as we approach 2030 and you know everything that means in terms of targets and funding, you know, building up the national funding buckets and in preparation probably for some, you know, changes in the external funding. So it's always a big word and a big project. And with the, you know, the move towards integration, again, as we're hearing, it should bring more scope and stakeholders, opening up opportunities for consolidation and for efficiencies. two more big words. And as UNAIDS very, very rightly pointed out, that's not just about the work in country. That's a big chunk of that. A big part of that is also about the technical partners and particularly the donors in terms of efficiencies and integrating. And we all realise that the donor money it comes with its own processes and so that's as UNAIDS pointed out, that's an important part of the discussion and it's good that can be taken forward as well. So the integration also brings opportunities for leadership at different levels in the health service, different levels in communities, within the Republic of Kenya, but also beyond the Republic of Kenya, as we said. And there's an opportunity here for Kenya to demonstrate leadership globally. We understand that some of the counties are already working in an integrated manner. So there are lessons to draw. There are some real life lessons that can be drawn upon, and the showcasing that we'll see in this meeting is important to begin to look at those lessons and how they can be picked up. And there are opportunities for innovation. With these changes as the context continues to evolve around us. We saw great innovations during the stress that the COVID pandemic put on the national and the international systems, and so there should be opportunities for innovation. And as I understand, after 2 decades of separation to a greater or lesser extent of the HIV services and the broader health services, it will be important to manage the transition, to look at the imbalances and to address those imbalances, to draw on the good practices from both sides, if you like, from the different places, and try and bring those together in the lessons and the innovations. And in doing so, important not to lose the gains. I hope you can still hear me. I had to press a button. Important not to lose the gains. We've had, we've had a great period of massive investment in HIV that is cooling down. So how can we, maintain those gains, including around community engagement, the role of communities, as UNAIDS has pointed out, whilst also taking the opportunity to build the resilience and sustainability of a broader integrated system. So I'll just finish with one point to say that it's timely. With the new Global Fund grants, as many of you will know, will be signed off next Monday to start on the 1st of July. So there's good there's the 3-year horizon now with the new Global Fund grants opening up. So the opportunities to work alongside this discussion, these plans, and look at where we can, guide the Global Fund investment to align with this effort. It's also timely for system strengthening. The new Global Fund grants include an increased investment in system strengthening, resilience, sustainability. These big words that keep coming up, and we need to look at those in a real manner. What do they mean? What do they really mean? And how can we direct resources and leadership to those areas? The investment includes tools that can be useful for the transition, such as community-led monitoring, which may help guide the transition to an integrated manner, and ensuring that we're not losing, but we're gaining as we move forward. So let me again thank you for this opportunity, for the invitation. Apologies for not being there, and for your patience in the technical link. So thank you very much.
Thank you, Paul, and apologies for the technical hitches. So anyone with a question to Paul before we allow him to continue with his business? Greetings from Kenya to you. I believe you are speaking to us from Geneva. Any question to Paul? There's no question, Paul, but people are awake. So that means they have understood.
Thank you, everybody.
Thank you very much.
Thank you.
Asante sana. Good. So I said we have only 3 presentations, and I meant it. People are looking at me and thinking, is it true? Yes, it is true. The presentations overly for today have largely been done. And as you can see, a couple of speakers were from the Ministry of Health, but as protocol demands, when the boss has spoken, no one else speaks. So we are not going to have those presentations from the ministry side. And for the keynote address from WHO, we will do this tomorrow first thing, when we are fresh, so that we can ask a few questions. So the keynote speakers are not asked questions. So that leaves us with only 1 presentation to go. Can we clap for ourselves? Do we have the Council of Governors in the House? They are not. So with that, therefore, to wrap us with the presentations, we have spoken, we have looked at the Kenyan story, the regional story, and the global story. We would like a wrap to come from the chair of the CCs for Health, Bwana Michael, to speak to us. Let's welcome him.
Thank you very much, Dr. Sirengo. Distinguished guests, ladies and gentlemen, as you have heard, my name is Michael Kibiwot. I'm the chair of the CCs for Health Caucus and also the CC for Health in Elgeyo Marakwet County. At this point, I am so sure that it is not the content of my short speech that will excite you, but probably the brevity of it that would make you happy. So I will try to go by your wish and be as brief. So foremost, let me take this opportunity on behalf of my colleagues. I don't know whether they can just stand up so that they can see whom I'm speaking for. The colleagues, CCs from several counties, stand up from wherever you are. Just wave to the crowd. I know they are accompanied by many directors and other technical officers. We recognize you wherever you are sitting. So foremost, let me take this opportunity to appreciate the acknowledgement that we have received in being involved meaningfully in this summit. To be able to see the many participants lined up to give their perspectives in this summit is indeed a testimony that counties have been recognized as places where the right things happen. I have seen the walls, and we are full of charts there that bring stories, very good stories, innovations from the counties. And there again, I say thank you for that recognition of the role of counties in driving this agenda forward. It's not by mistake, but rather by law, the function, the responsibility of delivering health services is almost 80% in the counties. And so we are in the right place. That said, I was looking and hearing from the discussions that have gone ahead, before us, that finally we are talking about 99, 98, 98, 96, something that a few years we didn't imagine was possible. And for that, I would like everyone to clap for themselves because I'm sure you are doing something. That acknowledgement is not enough if I do not mention particularly the government of Kenya for being very consistent. Again, the very, very consistent partners, particularly the US people through PEFA, through USAID, CDC, and there are many of their systems. Thank you very much. That you should get it from the counties whose responsibility for delivering health falls on. That said, we must remember that we are not yet there. The averages should not deceive us so that we forget that there are pockets that have been left behind, that there are subpopulations that have been left behind, that we have counties or subpopulations where we have missed targets, and even a few that for a few indicators, we have regressed. That should be something to acknowledge. And two, that even that 2% are people, are human beings. And so we must look back as we think we are wrapping up, go back and mop up and make sure everyone is at par. That is my request, so that we don't celebrate too early and move on. We achieved all this through a focused intervention, but then every solution, as you know, creates a problem. Every solution creates a problem. And so, because the end is in sight, when suddenly we hear the need to transition, words like journey to self-reliance, just make it sound nice. Sustainability, transition, domestic resource mobilization. You romanticize a bit, but we know what it means. I think when a drug is not palatable, you find a way to sweeten it, but otherwise it remains medicine. So that is how it is. Well, in my county, Elgeyo Marakwet, for example, we started discussing journey, or rather integration, as a means to achieving what you just talked about, the transition. Just as a means, just came out. And I'm happy to be here with one of USAID supported partners locally. AMPAT, Professor Kimayo is here with us. And yeah, you need to clap for that man. I am challenging you that once you get out here, just pick your phone and Google the name Professor S. Kimayo, and then see how many publications will come out. I hope your phone can manage. All right, so we have begun to discuss integration, and I said, as a way of curing some of the problems that vertical programming created. One, for example, we know that it has created people who are so narrowly but so deeply specialized. A cadre that is so narrowly and so deeply specialized. Do you agree with me or not? They know everything about HIV and nothing but HIV, right? That you cannot take that person to any other part of the clinic and feel like they want to work. Two, we have also created other cadres who know nothing about HIV. That recently when we had the doctor strike, we were worried. And I felt like I was so lucky that the strike didn't get to the the CCCs. If it was the case, I don't know how, probably would have managed in some of the places. I challenge the Cascos here. They are here. Please raise up your hands. How many of you, if today I asked to step in and see patients at the CCC, would be comfortable seeing those patients? You can see the hands. Yeah, so we understand. We've been with you all along. We understand that the way we have done things is that somehow we left behind we abdicated our responsibility. The support that came through made us a bit complacent, and suddenly we had standalone clinics there that are no longer known as GOK or county facilities, but rather people come and say, I'm looking for the HIV clinic. They say, "Iko pale, unaulizia AMPAT." You get what I mean? Unaulizia ECPAF or USAID this, CDC that. And the reason is because of the way it was done. So we need to integrate as a way to cure that and somehow spread that capacity so that you can transition smoothly. The second reason why we need to integrate is for us to be able to safeguard the way our programs, or by us having standalone facilities. Anytime you see someone, every other X date of the month comes and goes that direction towards the CCC clinic. It's probably enough to just, yeah? And yet we say we are confidential. I went to a facility in my county when I came in, and you could see clearly labeled those. And one of them is CCC. Just in the open, on the queue, in the OPD. Yeah? I feel with the level of stigma that we are talking about, could that be the reason some people don't come to clinic? Yes? And wish we had a clinic called a CDM clinic, where you walk in and you're treated for your hypertension and this and that, and HIV amongst others. The third reason is, yes, I said earlier, just promote ownership on the part of government. We probably have abdicated that role for a little too long. We don't think about it because we fund it less. Is it true? We don't fund it much. Even the budget, we know that the drugs are taken care of. But I was thinking the other day, like if we were to start buying the ARVs and all those commodities, I would actually have to double, or rather would have to double the amount of resources we spend on HPTs. So that is something. Lastly, we need to start deduplicating. We have parallel systems. Look at what we are doing, even starting from the national level. We have national syndemic disease, they call it NSDC, the formerly NAC, yeah? And then we have NASCO. Each one of them have committees or councils up there, the national government. You come to the counties, we have committees, they run. Then go down, you have CASCO, then SCASCO. Same this way, all right? Serving the same people. You can imagine as a default, a CHP going out to start tracing. Then suddenly, just a little bit, someone from the TB program is coming to the same family to trace a defaulter. Then just a little bit, another one comes from the HIV program to trace a defaulter to the same household. And yet, we now have a CHP who is assigned, who knows every member of the 100 households that they are managing, from the baby to the mother. And they almost know everything about them. Is it no time to integrate and save? And yet at the same time, will the communities feel safe to entrust their information and care onto this CHP, who suddenly, or rather comes from around and knows everybody and seems to probably be gossiping with everybody? So I'm just challenging us that yes, it is not a question of whether we must integrate. It is basically how we should do it. And if you ask me, the closest of the lowest hanging fruit is to start from the community and come upwards. At some point, we may have to have specialized clinics up there in the referral hospitals. We may have no choice. But down here, probably that would be the easiest in the counties to integrate. Let's think about it. And so that I don't bore you, I know you are Christians, some of you, or rather majority of you. And in Kenya, no speech ends from a politician without a quote of a verse from the Bible. And mine today comes from the book of Mark, verse 34, that says, "For what does it profit a man to gain the whole world and lose his soul?" So I should probably also ask, and this one is not from the Bible, what does it profit anyone to get healed of HIV and then lose their lives or health due to other illnesses like TB, or rather DM, HTN, that are easily manageable? Why can't we integrate and we serve everyone well? Lastly, I know if we are accepting that we should integrate, probably we are wondering how, we are wondering where. But I want to challenge us that someone must be courageous enough and try new things. If we didn't try all these things, if we didn't take risks, things would not have worked. So for example, I would be one of the managers in counties who would really love and welcome partnerships in how we can try out full integration and see things, how it will work. Yeah, we are committed to doing that, and we are willing to take and try things, except that we must be sure that we are ensuring that we are safe, or rather our clients are safe. We are willing to work with anyone who is willing to come up with this process and engage us, so that we can create a process that we can learn from, and then we can expand. Lastly, I know from these many good things that have happened, I am sure many of us wish we had done these good things a little earlier. Perhaps our mothers, perhaps our brothers would still be alive today. Is that a bell? So my last sentence, I wish and ask each one of you to do your best, so that one time when you look back, no one will say, or you yourself will not say, I wish I had done just a little more. Perhaps Mr. XYZ would still be alive today. With those many remarks, thank you. Thank you. Thank you.
Thank you, Kibiwot, for that beautiful sermon. The only thing you missed was a glass of water. It should have been brought here. Okay, good people, thank you very much for your active participation and attention. We have come to the end of today's presentations, but before we close, we had some pending business. There was a technical presentation from Lily, and another one, 2 presentations from the community, and I'm sure you wrote down your questions. And to lead us through that, I would like to invite Medina here, and Dr. Kinyanjui, I don't see him, who are supposed to help us conduct that session. Yes, please come.
Good evening. The chair has advised me that we'll take maximum 10 minutes to raise any burning questions or point of clarification before we forget if we postpone it to tomorrow. So I will invite the presenters to the podium. Dr. Lily. Yes. Joyce. Yeah, Dr. Lily, please come. Is Joyce in the room? And Nelson probably? Is Nelson coming, Dorothy? No. Nelson. Okay, so I don't see Joyce in the room, and probably you can contact her tomorrow or in the coming couple of days, because the 10 minutes will not really be sufficient for us to exhaust any question that you might have, but at least we'll take an opportunity to give a few chances for you to raise any important, all important, but any urgent question, because they have really presented quite substantive and comprehensive updates, especially the one by Dr. Lily, and of course Dorothy on the CLM in the 3 months from January to March. And I wish Joyce was here to talk about the Stigma Index Report 2.0, but she advised us also to look into the report, so hopefully we'll interact with the report itself, and we'll have an opportunity moving forward to raise questions and get clarification. So without taking much more time, I will open the floor for any question or point of clarification, because I have the two beautiful ladies here with me. Yes, Dr.
Thank you again. Mine is in relation to the data on the viral suppression among older patients living with HIV. From the data that Dr. Lillian had presented, it was 97% during the CAMFIA survey for the 50 plus and also 65 plus. But if you look at some of the data in the CCCs, we tend to sort of lose these patients after between 50 and 60 years. I don't know whether anyone has noted that. Is it that they retire and go to their homes, or where do they go? So I just wanted to ask about the attrition rate for that cohort, and also what is being done about ageism. Just the whole idea about ageism, that is a patient sick or not? Do the health worker know that they are sick or not, or is it just because of age? And whether there's something we can do about that.
Thank you very much. We take two more questions. Yes, over there, sorry. Is there a roaming mic over there?
Thank you very much. My name is Peter Odenyo. Mine goes to Dr. Lily. When you're doing program updates, you really answered so many questions that we've been asking as communities for PLHIVs. Because initially we've been talking about 1.3 million who are on ARVs. And then when we asked the question, out of that 1.3, how many are their medication working for them? Then you normally tell us, not you as an individual, but as a program, you normally tell us that the gauge we use is if they are virally suppressed. But today, you said what we've been talking about, that even those who are on diabetic, those who are their pressures are high, but if you get them, they are virally suppressed, but they are suffering with other co-infection. So that one answered that question. And now what my question on that is, how different are you going to approach that? After knowing that there are people on diabetic medication, but they are virally suppressed, but you said it openly here that we lose so many people because of that, but they are virally suppressed. Again, another one, Dr. Teresa alluded to on the management of pale HIV or elderly, those who've been on medication for some time. And he said that they are going to be managed. So how different is that one going to happen to manage those who are aging with HIV? Thank you.
Thank you very much. We have Professor on the left side, please.
Thank you very much. My question is to the CEC and also the NASCOP team. There's a question we have not dealt with here, and it is what skills do you need to do integrated care? To scale up HIV, we task shifted. And we task shifted and train people that narrow. You're right, we train that narrow pathway. But if you now want to integrate care, so I go see somebody, they see me, they sort out my diabetes, my hypertension, and my HIV, you need to increase the number of people who are highly qualified within those health facilities. You need to see integration, not just that the patient comes to a space that they're integrated, but the health worker is integrated. And who is a integrated health worker? Is a medical specialist, so those physicians or family medicine people. It is an obstetrician gynecologist. It is the nurse midwife, and that nurse midwife, you don't rotate her every time. You recognize that she's a specialist. Those are the people who have the skills, or their training is geared towards providing integrated care. So that piece of the discussion is not being held. And to be able to sustain a continuous flow of those kind of cadres, you need to build medical specialist training. Counties, you need to have medical specialist training that is going on, because the context of medical specialist training gives you a consultant whose work can be expanded as he trains people. The people who he's training or she's training are able to expand their work or the skills that that person has. So this model, and I think as the UN you go forward to discuss this tomorrow, the medical specialist training program is key to us moving towards this integrated care and quality care. Thank you.
Thank you very much. All the three questions that have been raised so far goes to Dr. Lily, and maybe in the next round, I will invite any questions for Dorothy on the feedback through the community-led monitoring. So over to you, Dr. Lily.
Yeah, thank you very much. I take like two questions were sort of like comments, and I feel like Prof. Ndwati has helped me to respond to the question. One of the question was asked, so we have found that, or rather we observed that we have these clients who are living with HIV who are virally suppressed, but are not well controlled in terms of their hypertension or diabetes. And so what are we going to do about that? And in the presentation, I did mention that that is really a small subset of the data that we have at individual level. And so we're able to do a lot more analysis to really understand who these people are. So the first step is really to understand. And if you took note of the characteristics of the people who are poorly controlled diabetes, were the much younger population and the extreme older population. So one is by taking note of the characteristic of the populations and the subpopulations that are poorly controlled. And then, of course, I think the answer lies in what Prof. Ndwati has talked about, and I think also the presenter that presented at the very end, the CEC, that said that the program has created a very super specialized clinicians who are only focusing on HIV, and that is why you saw in our data, our clients are well suppressed because we are doing everything we can to manage the HIV, but then sort of like forgetting or relinquishing that function to other clients. Secondly, of course, we do know that while access to HIV treatment is free, it will not be the case for the other chronic diseases. So chances are maybe these clients are erratic in terms of their adherence to their treatment. And so it requires a broader conversation. And I believe we do have sessions tomorrow around what are the scenarios that we envision in terms of ensuring that we are adequately integrating, including who pays for these services. And I'm glad that during the CSS speech we were assured that clients are going to be covered within the social health insurance to be able to take care of that. I think the question by Dr. Triza around ageism, I may not be the right person to comment about that, so please allow me to pass. But I do agree with you, Dr. With the data that we have at the National Data Warehouse, then you're able to actually see much older clients, like doing more poorly for various reasons. About the function of ageism, I would want to relinquish that to somebody who has better capacity to respond to it. Asante.
Thank you so much, Dr. Lily. So I open the floor. Any question to Dorothy on the feedback that she presented to us through the community-led monitoring that they have conducted in a couple of counties, if any question? Which means, Dorothy, it was very, very much clear. What you have presented was very clear, or maybe it was short. So, yes, Brian.
Let me just say that it's not a question, it's actually a comment. But my hope really is that these are both things that we can regularize so that as we look at that CLM report, that it's actually integrated into the new structure that we have for reporting within NASCOP. Because I think that both of them were just fantastic. And I really am hopeful that CSOs and the community really appreciate being able to see all of that information in one spot. And I think as we move forward, we're going to try to do that. Probably not within a meeting space. It'll probably be more virtual, but it should be integrated in together as well.
Can I ask a question? Yeah. Dorothy, from the experience of doing CLM for HIV, given that we're discussing integration, how could it be applied across multiple diseases or across, the integrated services that are beyond HIV? That for me is my question.
Thank you, Anne. I think as we are presenting issues on HIV, I think we have TB, the CLM for TB, we have CLM for other diseases. So I think what we are going to look at is have one platform that we can have all the diseases monitored, because just like one of us said that we need to actually look at the little resources that we have. So if we have all of them integrated into one, then that would be something that I think could help. I know in terms of HIV itself, for the clients that we did interview during the data collection, they actually wanted to have a one-stop shop where they can actually have their medication without anybody knowing that they are going for HIV treatment. So I think when we talk about integration, this is something that will really help us. So when you go to the queue, and like the doctor has mentioned from Elgeyo Marakwet, when you go to the queue, you are not, it's not like this one actually is coming for ART, or this one is coming for diseases that maybe opportunistic infection that come as with HIV. So I think that is something that we need to talk about, we need to discuss with both UNAIDS, with the communities, and of course the development partners that we work with. Thank you.
Thank you very much, Dorothy. Dr. Rose? would you like to comment on some of the issues that were raised, including by Professor Nduati or any other?
Good evening. I think Prof. Duati has raised an important point around what we might end up coming up as some of the issues that we need to address as we think about an integrated program. So I don't want to preempt because those are some of the topics that are actually for discussion, but it's an important thing to consider. I wanted to just comment on the issue of HIV and aging, which Dr. Garcia raised. I think based on published information, the relationship between HIV, aging, and comorbidities is well documented, where either by the virus itself or just aging process, the occurrence of comorbidities is increased within the populations. But we also see a reality that as people age, there is the reduced social networks that are important for anyone living with a chronic disease. And there's also transition. So for example, from your workplace, retiring back to the village or in a different place. And so one of the things we are doing as a program, Daktari, is what our UNAIDS Regional Director talked about, data and evidence-driven programming. This data we are presenting was not there 10 years ago. We didn't even know by our cohorts how many are screened for hypertension, diabetes. But today, we are presenting evidence that in our clinics, this person who is aged this, when screened, these are the numbers that have hypertension. And that's the beginning. I think the beginning is first of all to say of our 50-year-olds or our 60-year-olds, how many have hypertension even as they come in with HIV. And this is a powerful thing, and that is why the program has been pushing for digitization and patient-level information. Because today I may not have hypertension, but in the next 2 years, in the next screening, that may be something I need to respond to. And that is critical for anyone in the clinic to know what they are dealing with. I think the second thing the program has invested in, actually pushing for M&E systems that look at beyond HIV, and that is why we are able to give you this data. We are hoping that sites and facilities can use these insights to know the client they're having and look at them holistically. Of course, the issue of how the capacity of the healthcare worker is critical. One of the challenges that we have is around the lab systems. So previously, we have invested in viral load assessment and CD4. But the issue of biochemistry and liver and kidney functions is something we probably forgot 5 or 10 years ago in terms of investing. And we see it as a challenge. So as we are discussing today as a program, when we quantify, we are asking ourselves, how do we best expand that space around monitoring, lab systems, or even within the systems that we have, how do we have broader assessment? So that's a question we need to be discussing around how we move forward. In terms of HPMTs, we have tried within the HIV program to ensure that the treatment options that we give are alive to the comorbidities and the risks that some ARVs may have on the issue of the comorbidities or the struggles like kidney disease, that we may need options that are safer. So as a program that we have already factored in. But talk about the HPMT for the now hypertension or diabetes or kidney disease. We don't have a supply chain system that affects that. However, recent data from Malawi and Uganda has shown that just by integrating the healthcare worker who can speak to the client, even when you don't have a pre-financing of that product, the client is more empowered to go and look for the drug and is more taught about adherence. So yes, in terms of treatment, we may not have solutions, but just by having an integrated healthcare worker, we believe it makes a difference. My happiness is that this forum, we have programs, clinics, counties that have already tried to integrate this, and it would be good to see what we can pick from here as a program and move forward, but also more holistically as a ministry. Thank you.
Thank you very much, Dr. Rose. I think we have come to the end of this plenary discussion for today. Obviously, we'll not stop here, but we'll continue interacting in the coming couple of days, and we have opportunity to interact with our presenters. So join me in thanking Dorothy and Dr. Lily for the excellent presentation, but also for responding to the questions that we have raised. Thank you very much. Yeah. So thank you so much for your participation. I know it has been a very long day, but very, very interesting. with a lot of rich discussion and presentation, and we'll continue with the announcement from our chair on what next for today or tomorrow. Thank you.
Thank you. Thank you, Medina. This brings us to the end of day one. It's been a day and a half, isn't it? Can we clap for ourselves? Special thank you to the speakers of today. Thank you for making our day. Thank you to all the audiences in the room. And thank you to the organizers for this event. Now, as we walk out, I would like to request a few photos. First, the speakers, and then the partners in the room. Then we have the CCs, the CASCOs, the ministry officials, the county officials, the implementing partners like that. We'll all come here. I ask for some assistance. Just as quickly, let's put some seats up here. Our speakers for today, kindly make your way up here. The early birds will sit, the late ones will stand at the back. It goes without saying. Charles, you sit at the back. Lily, please come quickly. And shall I say the chairs also? Come on. Professor Ndwati, I'm told this photography cannot end without you. Counties, speakers, if you can still remain, if you so wish, so that we have CCs to join. CCs, please. CCs, please join us in the photo. Next is all our development partners in the room, followed by implementing partners, then CASCOs, county health directors, like that. Okay. Pictures, pictures. Okay, county directors, followed by Cascos. Brian, you are permanent in all photos. Plus Anne. You are permanent in all photos. Plus Anne. And Rose. Okay, directors for health, please. All right, please give your best smile, Instagram moment. Thank you very much. Cascos. Cascos, please hasten your steps. Development and implementing partners, you are next. Please get ready. Cascos. Sorry. Can you see this gentleman? He's in the photo also. Not me. Okay, smile, say cheese. Thank you very much. Development partners, implementing partners. The next is community and young people. The next is community and young people. Then last but not least, MOH. Okay, wengine? This is the biggest photo. It's equivalent to the size of the envelope. Okay, now please get ready for the photo. Can we say cheese? Somebody is out of the photo. If you miss in this photo, you'll be asked whether you're in Mombasa. So please make sure you are in. Okay, can we say cheese? Cheese. Thank you. Next, Ministry of Health. Oh, sorry, community and young people. Community and young people, then lastly, MOH. Community and young people. Young people, where are you? Spoken word, Kerry, Baridi, Justus, where are you? Ingia kwa picha. Ministry of Health, please make your way up here. Ministry of Health, make your way for the photo. Okay, ready? That photo has not, we have not filled the photo. Okay, let's say cheese. Thank you. Aya. Ministry of Health. NASCOP and its community. Ministry of Health, NASCOP, NAC. This is the last photo. If you have not been called, also come.